Okay, good morning, everybody. Again, best greetings from Zurich. We had now the presentation of Dr. Burkhardt, my successor and actual president, and also in the name of Joachim Mörtel, I greet the Ukrainian people for this meeting. Now we go back to history. In 1989, in the consequence of the Brussels meeting of 1988, the three founders, Kambin, Schreiber, and Hijikata, made the first steps to form this constitution of ISMIS. And it became then affiliated to SICOT in the 1990s. And we had then a period of all 4 years for president's election. We see here the names of all these worldwide splitted presidents. You see here again Hijikata, Schreiber, Kambin, Schreiber and Kambin, and Schreiber and Benazir, one of the first presidents who died later in the charge. We had also to define the goals and achievements of ISMIS in the last 3 decades. As you see, we had several meetings world over. The goal was always to involve the members in the first revolution and practical competition and exchange of minimally invasive spinal surgery. We tried also to encourage the new generation to follow the steps of the ISMIS goals. So we give also some guidelines for minimal invasive surgery. We had in 1909 already the first worldwide published guidelines for percutaneous endoscopic spinal surgery. And we tried to give some help also for the definition of the indications of the examinations and also of the controls then of the patients and further publications. We had then the 33 ISMIS meeting in Zurich, Switzerland, that I had the pleasure to give since 87. And the last special guest lecturer was Richard Fessler, the former president of ISMIS. You see here again Hijikata when he went to Zurich in the 90s. Then I would say when everybody is interested in ISMIS, he is welcome. We try to apply the optimized minimally invasive techniques. We try to define the best indications because the best technique will not better than its indication. And we try to give courses, as you have here also in Ukraine, to foster the competence of the colleagues in this field. So you can visit ISMIS webpage and see how you can also get member there. Now the parola remain optimized invasive techniques, selective indications, and minimal invasivity. That was the look back on ISMIS, the society. Now I switch to my presentation of our 40 years of experience with this kind of technique. Endoscopy has an old tradition that was not so in our view in maybe the last 20 years, but if you go in the literature, you find already Bossini with the Lichtleiter for bladder investigations so early as 1806. Then we had in Austria Mikulicz-Radetzky, who made the gastroscopy with a rigid system with the first time electric illumination. It was on batteries, as you see here on the right side down. And then it was Jacobaeus in Sweden that developed the first lens thoracoscope that was then also used from other people like Eugene Berger in Switzerland in the 20s for first applications in the knee. So he used the thoracoscope there first time for investigation in the knee. So endoscopy went also to orthopedic surgery, to joint surgery. We had then the first worldwide publications on disc herniations and the caudal compression syndrome pathology. That was then followed by Mixter and Barr with the technique of intervertebral decompression. So this was the open surgery. We had then in the 48 the first percutaneous applications with a trigonometric system of X-rays for Pott's disease to evacuate the putrid zone in the thoracic area especially. Ottolenghi was an Italian that migrated to Argentina, and in the same time, early 50s in Germany, after the Second World War, the endoscope devolution of the optical fabrics was again activated, and they developed the first rod lens laryngoscope for application in the clinical with also electrical illumination with a separate illumination channel. In the field of the surgery, minimal invasive techniques, maybe in the consequence of Ottolenghi, then Lyman Swiss developed in the 60s the chymopapine application. This is a kind of chemical dilution of the herniated disc. The problem has been that this was not so steerable. Sometimes the disc collapsed completely, and sometimes you had no really good result. So it was difficult also because chymopapine was very allergic. So some people also had problems of allergy that could not be managed at that time. In the field of stabilization, we had then Racamil in France, who made the first publication on plate application in 1970, just to see what is going on in the field of stabilization. And in the endoscopic, then it has been Parvis Kambin, who was the same time as the Japanese Ichikata in 75, who invented and introduced the minimal invasive disc decompression by cannula system with Kambin still in combination with open surgery. And Japanese Hichikata then the purely closed decompression by a needle system, a little bit enlarged needle. He was then presenting that at the SICOT 78, and so there was the step then to Zurich. In Europe, we had then Kaspar, who introduced microdiscectomy, who is still a golden standard worldwide today for interlaminar decompression. And Suezawa in Zurich, he came from Japan in the 70s. First introduced then the Japanese Ichikata technique in 79 for the first time in Zurich, Switzerland, with this tiny enlarged needle system. You see here image down here from the first applications. The problem has been there that this was very few effective for the European larger sites, and also going in and out had a little bit the problem of some maybe infections and inflammatory reactions. We had then further decompression with discoscopy introduced by Schreiber in 82. We had then the interbody fusion that was introduced by our team then in 88, and the foraminal uniportal decompression that we introduced also in Switzerland in the later 80s and clinically in the early 90s. Now let's go back to see what is the endoscopic decompression by a biportal approach. It was introduced in the mid-80s, that you have from the one side the endoscope and from the other side then the instruments that taking out this migrated disc material. This was the first publication in the book of Hohmann in 82 about this endoscopic techniques of interbody decompression. We had then to modify a little bit the instruments with suction punches, as you see here on the right side, that avoided always going in and out. You could, with the aspiration system, then take out a little fragments of the migrated disc material by this suction system. So we used then also first time the angulated Storz-Hopkins endoscopes that allowed a better exposure of the posterior zone and not just looking right in front. and this was the goal was always here to decompress the posterior part. We had a learning curve, absolutely, also in this kind of decompression, that we had to learn to apply the cannulas in the posterior part, not here. When you decompress in the front, then maybe you increase instability, but you hardly make a pointed decompression, as then in the later series we reached with the flatter entrance part of the cannulas. This is also learning curves there. We had also some pitfalls, as you can imagine it. When you have a new technique, you must learn to handle it. You must find the best indication. We had also some aseptic end plate information due to the irritation by the mechanical instruments of the end plates. So be careful when you touch them. That may be also a risk of reaction that you would not like to have. We had then in the mid time follow-up of 2 or 3 years about 65 to 80% good results. And when you compare with open surgery, it was then absolutely minimally invasive at that time, already a step ahead. We tried then different kinds of additional tools to improve this decompression. We had then the neodymium YAG laser that was introduced by the Austrian Ascher. We made different trials also under endoscopy. We used then also neodymium lasers and modified, but it had been very cumbersome because you burn when you come from one side with the laser, you can burn the optic system from the other side, and the efficiency was not better than mechanical tools. So it was then since mid-90s no more in use. When you see now the restabilization ID with the percutaneous technique, you had already in 85 John Shepherd from Great Britain, who introduced the interbody doweling. It was a bone pick that he took from the iliac crest, and after decompression, he applied that in the intervertebral space. You see here one of these images. The problem at that time was that he did not open the end plate, so he had no contact between the bone he implanted and the living bone, and so this was not a very successful trial that he made. So we picked up the system for the interbody elaboration, ID for the fusion. Then in the later 80s with the external fixating device that was introduced by AO in 85 by Fritz Margel in St. Gallen for traumatology applications. And we used that then for distraction of degenerative disc segments. And when the patient was fine, then we combined it with the interbody opening of the end plates after decompression. You see here the entrance of the eccentrically abrasive milling cutter that allows you to penetrate the end plates to make a good living bed for the implanted autologous bone. So you see here the wide opening of the end plates and the bleeding bed for the bony fusion. So this was a remarkable step in the technique of restabilization by endoscopic intervertebral techniques. You see here the application in the OR after several days of good result with the external fixator. We added then the interbody fusion. One important step was that you pick the bone picks that you implant immediately before you have the cannulas set in. And first time we took the bone picks when we applied the external fixator. We put that the bone banks, but this was not a good idea because in the bone banking, you have no more the same vitality of the bone as if you implant immediately. Here we have a long-term result of 11 years. You see the interbody fusion in this slip with spondylolysis. We see also that after several years, there is remarkably less adjacent disc disease and facet disease than you would expect with open surgery. So the minimal invasive techniques spares the muscle system and spares the adjacent segment by the open techniques. It was obvious that the external fixator device was no more so accepted than in the 90s, so we had to switch then in the early 0 years to the sextant system and other system to add the stability for the fusion. When we see the first evolvements, then in 91, we introduced at Balgist the uniportal decompression for extra discal fragments in the terminal area. You see here the system coming from the side. This was specially adapted for lateral disc herniation in the foramen. You see here this position of this extrusion towards the exiting branch of the neurological system. And when you enter here to decompress key card, that you don't enter here, but start here and then work up by decompression without hurting here the ganglion. That was also some technical improvement that we had to learn, that we must really start from the lower part and working up decompressing the system. You see here the application of the guide needle and then the cannulas. The system was then developed further with the Storch company with an improved urological instrument, and you see here the fragment extraction by the tubular guide. Sometimes you cannot pull up across the system, but you must pull out with removing the system from the cannula. You see here the typical decompression in the subligmentary area. You see here above is the thecal sac, and if we decompress and undermine here the decompress the protrusion and the extrusion of the fragments before we have to remove the foraminal part of the disc, which is shown here. You can put it from one side with 2 hands, it's okay. We had then also the option for better control of the bleedings that sometimes can be also cumbersome for the irrigation system. We had then this electrical coagulator with Surgitron technique. It is still in use for decompression under water because it's the only system you can use under irrigation. But we found that it was hardly necessary to use this when you have a cooled irrigation fluid. When you cool down the irrigation fluid, ringer lactate or the saline to about 6 degrees, then you have vascular constriction and you have much better view under endoscopic control under irrigation. So this was a big step that we could avoid it to use often with only cooled system in the wartime. We had also pitfalls with this system. As you can see, you had an improved system now with this uniportal in comparison of the biportal. But the biportal is also a bit more invasive. You have irritations from both sides, and when you have that only from one side, you are less invasive than from 2 sides. We had also to learn to not wait too long, because when you wait for more than 6 weeks with these foraminal extruded materials, you may have some scares and problems with extracting. So when you have the diagnosis in the early stage for about 3 to 5 weeks, the chance to remove efficiently by the endoscopic system is much better than if you wait a longer time. When you have a good new system, then you have big interests also elsewhere. You had in Italian Society of Spinal Surgeons, then Fontanella, who developed the same system also for the cervical application. You can see that here in the sequential uniportal application. Then we had the Jean Destandeau, who was introducing a tubular system for decompression. That was the first that could be used in the interlaminar and extra articular approach. It is comparable to microdiscectomy, but it's not a microscope, but it's an endoscopic system that you introduce across a larger tube. It was a bit more invasive, but it was effective also for the interlaminar applications. And he is probably the most experienced surgeon in Europe that you have with the tubular system with these larger system tools, and he's still using that and very successful. Here we have then the modification with the smaller tubular system by Yoshida in Japan. In the year 2000, he published here this system that was then took over by the Americans and is still also modified with newer techniques in our days with the new Storz EasyGo system. It is the base of the tubular, smaller tubular system that we had. Then we had colleagues that developed the purely interlaminar endoscopic approach, such as the Rütten in Germany, a very nice technique that we took over also, and it's nice to use it for L5S1, but when you have quite a large window. It is cumbersome in my experience in the level above where it's more restricted the approach, and you have to do more bony work that is maybe at the end not more effective and minimally invasive than microsurgery. But for the L5S1, I found it very helpful. Then we had also the techniques of enlarging the foramen by these drill burrs with diamond structures that was introduced in 2005 by Desawa, and this had become a standard system also in Europe, also for microdiscectomy. It's very helpful, this different shape of drill burrs. It has been then Joachim Mörtel in the early years of the century who took over this Yoshida system and improved that, especially with also larger tubes, then also for the European side with the coaxial endoscope system, not with like this one was angulated, and this is coaxial. And this is now the technique that we use also for interlaminar. You have here an example of removal of the rims of the lamina and the exposure of the thecal sac, and then removal of the fragment that are migrated in the recess area. It's quite effective and very minimally invasive. And this is now without irrigation. This is makes a little bit easier the view, because in the area when you have to do match bone work, you have more bleeding as you have when you go only to the foraminal part. So this was the technical part. Now, when you see all these kind of herniations, you have here a field for interlaminar, and here a field for translaminar localization of the herniation. Again, here in the interpedicular area, probably the microscopic technique is still the more secure techniques, but all what is in the foraminal area up to the mediolateral and interlaminar approach is accessible nowadays with the endoscopic system. Absolutely, when you compare the efficiency on a long term, you see that after some 2 years, the result of micro-endoscopic open conservative treatment that you still can do when you have no neurological deficit can be comparable. But the way that you go, when you go here with the endoscopic techniques in the adapted indications, it's much quicker to go back to work, to less pain, more muscular recovery when you have an early decompression by an endoscopic system. So you never get with any techniques absolutely 100% result, because also with minimal invasive techniques you cannot not end the natural course of the degenerative disease. So the recurrency in herniations is not depending on the decompressive system you use, but it's depending on the natural course of degenerative disease. This you have to keep in mind when you discuss indications and compare the different techniques in the long term, because you get about a limit of 85% of natural history of this disease that you can't change. Then we have also not only the techniques, we have also to see in which socio-economical surroundings we are working. We have problems with the hospital costs, we have problems with wage compensation, we have problems with product income that you must compensate by insurance or by go back early to the work again. And this is something that we have to consider when we see also the techniques. So in our experience, the minimal invasive techniques are advantages because you get earlier go back to the work, to the social contribution of the patient as you when you use conventional old techniques. But I have to repeat again, if you see that your only tool is a hammer, not everything is really a nail. So do the right thing with the right OP technique and do it in the best time. As I mentioned, the best window of surgery is 4 to 6 weeks. Now, when you would like to learn more on these techniques, you are welcome also to our actual ISMIS courses. We have the 40th course here in coming autumn. And my thanks go to the organizer of this meeting, Dr. Balan, Piątkowski, and Radchenko. And I wish you a very successful meeting further this day. Thank you.
Thank you very much.